I just want to start by disclosing my main means of support comes from the National Health and Medical Research Council and Arthritis Australia. And I'm on the scientific advisory board for some what's called disease modifying agents. So these are agents that hopefully will come to the FDA for approval in the next 3 to 5 years, and then modifying the course of the disease. So they're not currently available. For those of you that have a particular interest in this area and want to read more, these are some references that might be helpful in that regard. Largely centered around health service system delivery for this chronic non-communicable disease. And I take a very different take to osteoarthritis to the way we currently approach it, and hopefully that will come through this morning's presentation. This is what I want to go through. I'm going to talk about the burden of the disease, talk about the aging of the population and obesity and the impact that's having on the number of people that have disease, look at the projections, both in terms of healthcare delivery, but also in terms of service utilization, and the ways that as a health service, you potentially could consider attending to this. And then look specifically at advanced stage care or surgery. Now, over the last 30 to 40 years, we've seen dramatic improvements in life expectancy, largely by virtue of reductions in the number of people who smoke. So there's been a lot of improvements in the number of people who smoke, and that's led to vast and dramatic shifts in life expectancy. And you'll look at that and say, well, that's fantastic, it's tremendous. And the average age that we live to now is about 85. And I'm probably going to sound a little bit cynical, but bear in mind that the average age that you live to is 85, but similarly, now the mean age of diagnosis of osteoarthritis is about 56. So back in the 1990s, the mean age was about 69. It's dropped dramatically, largely by virtue of changes in obesity and increasing numbers of joint injury. So we're seeing osteoarthritis at a much younger age. So sure, we're living longer, but we're also living longer for those people that have osteoarthritis with the disabling consequences of this disease. So what is osteoarthritis? Hopefully you're all here to hear about osteoarthritis. If you're not, you're probably in the wrong room. But essentially it's a disease that can affect any of the synovial joint tissue structures. Historically, we thought this was all about cartilage, but it's important you understand that it's not. Cartilage is not responsible for why a person comes along complaining of pain and limited function. It doesn't contain nerve fibers, so it can't be cartilage. It can obviously affect any of the synovial joint tissue structures, the bone, the muscle, the lining of the joint, the synovium, the fat, the meniscus. So that's the structural change of osteoarthritis. But the illness, as opposed to the disease, the illness is a person coming along complaining of pain and limited function related to that underlying joint structural change. This is incredibly common. As Philip mentioned, over 400,000 New Zealanders have osteoarthritis, 1 in 8 adults, 250 million people worldwide. And this is the leading cause of lower limb disability in older adults. To give you some more focused data on New Zealand, this is some data that Haxby published back in 2017, looking at both the non-Maori and Maori population. And you can see in the non-Maori population that this is a disease that's more common as you get older. It's more common typically in women than it is in men. Interestingly, in the Maori population, there doesn't appear to be that discrepancy between genders, and it appears, if anything, to be slightly more common in men than it does in women. But again, incredibly common amongst our older individuals. Just understand, however, that this isn't just a disease of older adults. 2/3 of the people that are affected by osteoarthritis are of working age. And the importance of that is that's where a large portion of the indirect costs come from. This is, in many countries, one of the leading causes of premature retirement from the workplace. And obviously that has a huge economic impact when we're thinking about this disease. To put this in terms that relates very much to the advocacy of Arthritis New Zealand and the concerns that patients have, for 2 in every 3 people that are affected by this disease, the last time they were pain-free was over a year ago. Okay? And so this is a disease that has an average time course of about 25 years. So you can understand the personal impact that this disease will have on a person that has osteoarthritis. Now, for the average punter in the room, 0.5% of the GDP doesn't sound like a lot of money. but I'm sure if I told your political colleagues that you could get back 0.5% of the GDP if you weren't having to manage osteoarthritis, you would take that in a heartbeat. So this is an incredibly expensive problem. These are data from Australia back from 2013. So they're a little bit old, but essentially reflect the 2012 economy and budget. As far as direct healthcare costs in Australia is concerned, we spent $4 billion, and that was a 4 times increase since 2000, and that's largely being driven by increased interventions, which I'll come to in a moment. For every person that's affected, it's about $1,700, and this is about 41% of all musculoskeletal conditions. So if we look and take that into account, things like back pain, rheumatoid arthritis, other inflammatory joint conditions, gout, this is about 41% of the total cost of musculoskeletal conditions. And those costs, in large part, are being driven by surgery and recovery from surgery, so rehabilitation costs. So about 75% of the cost, the direct healthcare cost for this disease, is being driven by elective surgery and recovery from surgery. And much smaller proportions of it are being spent on outpatient costs and other professional services, which is where I think we largely should be focusing much of the healthcare system going forward. Now, the direct healthcare costs are massive, but the indirect costs in general are a factor of 4 to 6 times larger than those direct costs. So you think the direct costs are large, but the indirect costs are much, much greater, and largely relate to this premature retirement, absenteeism, and presenteeism that comes about as a consequence of a person who has osteoarthritis. Again, 2/3 of the people that are affected here are of working age, and the productivity costs from that are immense. For the economists in the room, I know you look at this and think, well, gosh, David, this is, again, just Australian data. It doesn't relate to New Zealand, but I'm sure it translates probably reasonably well. So the loss in GDP is massive, again, largely coming again from factors related to those indirect costs, absenteeism, presenteeism. This accounts for about 13% of disability. It's the second most common health condition forcing Australians from the labour force, and that accounts for about 134,000 Australians who are out of the labour force due to this disease. More importantly, from an individual perspective, when we look at the impact this has on savings, superannuation, and poverty, this disease is terrible, okay? Whatever way you look at it. Greater than a 75% reduction in total weekly income, and a large portion of them are not in the labour force, and that obviously accounts for a large proportion of them not having sufficient wealth going particularly into retirement. So it has massive both societal and individual costs. And when we look at the changing demographics in our community and the impact that this disease will have going forward, even under the most conservative estimates, so at the moment if we estimate that about $20 billion, both direct and indirect costs, is being spent on this disease, if we look at the total number of patients that are affected moving forward, taking into account obesity, age, joint injury, you can see that there's dramatic escalation both in terms of the number of people that are affected by 2050, but also in terms of the total cost. So if we don't do anything about this problem, it's only going to get worse. And that's really what I'm here to try to reinforce today, is different things that we can do. So towards the latter end of last year, we launched what's called the National Osteoarthritis Strategy in Canberra. And we essentially have this under 3 pillars: prevention, living well with osteoarthritis, and advanced care. And I'm going to go through each of these through the course of this morning's presentation, focused very much on opportunities for us to intervene before a person requires surgery, because ultimately that's where our healthcare system may survive, other than if we don't do anything about it. But I'm going to start off by talking about prevention. About 75% of a person's likelihood of developing osteoarthritis of the knee relates to 2 factors: overweight and obesity, and joint injury. Both are eminently modifiable. Both, from a public health perspective, we do very little, if anything, about. From an injury prevention perspective, about 20,000 Australians tear their cruciate ligament every year. And that usually comes about by virtue of non-contact injuries in sport, similar to what Quade's doing to his knee right here, right now. So it's not about trauma, it's not about impact. It's about landing on your knee at the wrong angle, as opposed to the ideal angle. The standard way this is managed in Western countries at the moment is through cruciate ligament reconstruction. and that's the typical way it's managed. Unfortunately, that does not change the likelihood of long-term risk of osteoarthritis. 70% of people who tear their cruciate ligament will develop osteoarthritis within 10 to 15 years. The average age these injuries are happening is at 22. These people are developing osteoarthritis of the knee in their mid-30s, early 40s. So again, cruciate ligament reconstruction does not alter the long-term risk of osteoarthritis, but neuromuscular training, so teaching people how to land on their knee properly like that as opposed to that, through programs like the FIFA 11, Safe Sports for Kids, the PEP program, can reduce injury rates by 60 to 70%. And that's being done on a country-wide basis in countries like Denmark and other parts of Scandinavia, and has a massive impact on injury rates. But unfortunately, at a grassroots level in countries like Australia and New Zealand, this isn't happening. So a huge missed opportunity to target directly the reason why 20% of people develop osteoarthritis of the knee. Now, if we were to do that as a community, again in Australia, and I apologize for that, but if we were to roll out a program which costs in order of about $1.5 million per year to train our coaches and trainers to deliver this at a grassroots level, we would ultimately be saving in the order of $99 million per year. So again, $1.5 million per year, ultimately be saving $99 million per year. And you're going to say, well, obviously they're not going to have a knee replacement straight away, but ultimately they probably will have a large proportion of them having that. And this is just direct costs. So if we just reduce the ACL reconstruction rate by about 40%, which is a very conservative estimate for the impact of these injury prevention programs, we'll have an automatic direct impact on the number of people who require ACL reconstruction. So it's incredibly cost effective, but unfortunately at this point in time is not happening from a community perspective. Now, most Western countries have a big problem of obesity and overweight, and that obviously in large part takes into account the fact that we're both eating more and being less active. There's lots of societal influences that are having a big impact here on the reasons why people are becoming more obese. Obviously the caloric intake is important, but in addition to that, the number of hours that we're spending being sedentary as opposed to being physically active appears to be going up with time. So if you look at the projections in terms of the number of hours that we spend being sedentary per week, you can see the general trajectory is one of going up and up and up. And if our lifestyles continue to be one where it's easy to access caloric-rich food, and it's easy to sit around and not do as much activity, you can understand why the impact this is having on obesity and overweight. So about 2/3 of many Western countries around the world now are overweight or obese by virtue of those societal changes. And that is having a tremendous impact on the number of people who are developing osteoarthritis. As a society, there's lots of opportunities for us to make a difference. Ultimately, at the moment, and if we look at the public health agenda, this is some data that came out in The Lancet some time ago, but it's still very relevant now. This is looking at the net cost per disability adjusted life years saved, and anything that lies above here is cost saving to our community. Anything that lies below that blue line is not what we would consider cost effective. And that includes things like Weight Watchers. So the individual responsibility taken is important, and it's important we don't deny a person's individual responsibility and taking responsibility for their weight control. But if we try to do this from a public health standpoint to the whole community, programs like that are not going to be cost effective. As opposed to putting taxes on unhealthy foods, increasing physical activity amongst school kids, banning junk food advertising, a lot of things that in many countries are unpalatable because of the power of the sugar and food advocacy groups. But ultimately we need to do a lot more as a society because this is where most of our disease is coming from, is from obesity. These things are cost saving and we really need to be proactive about this. Again, 45% of the reason a person develops osteoarthritis of the knee relates to this, obesity. And from a public health perspective, there's lots of things we can do, but unfortunately many politicians seem a little bit powerless to do anything about that at the moment. Okay, so thinking about it automatically and translating that specifically to osteoarthritis. So if we had a base case prevalence of osteoarthritis of about 10.7% and we reduced the number of people who are obese by 5%, Obviously, that would have a big impact on the number of patients, the total economic cost, and the net savings in terms of billions of dollars. The more they lose, the better, okay? And again, that's from a societal perspective, thinking about this from a public health perspective. All right, so thinking about our management of osteoarthritis as it currently stands and what we ideally should be doing moving forward. This is where we currently stand. So if we look at many of the chronic non-communicable diseases, many of them are receiving appropriate care. And this scale looks from 0 to 100 in terms of the percent of appropriate care received. And many of the diseases are very common in our general community. Unfortunately, for osteoarthritis, on average, about 40% of people are receiving appropriate care. And I would suggest to you that that's a very generous estimate. Where are we failing? Well, ultimately, we're failing in lots of different reasons. Most of the people who come along with osteoarthritis have pain and limited function, but we're not asking them about that as part of our clinical assessment. About half the time, we're not even asking them about that. About 2/3 of the time, they're not being advocated the appropriate non-drug treatments of education, exercise, weight reduction. About 2/3 of the time, they're being prescribed the wrong medication, but we're doing pretty well at referring people off to surgeons. So you can see there's dramatic areas where we can improve upon our traditional management. And many of you will say, well, you know, that doesn't relate to us. Our management is perfect. This is some more recent data from a study called the Beach study in Australia, which looked at the frequency with which different interventions or referrals were happening in general practice. You can see that imaging occurs much more commonly than referral to the orthopedic surgeon. But most importantly, the things that actually do provide a benefit to patients that ideally should be first-line care is happening much less frequently than either of these indications. If we look at the number of people being referred to a dietitian for weight reduction, it's much less than acupuncture. So we're going to make a meaningful difference here and get traction with our patients about exercise, about diet, and we don't refer them to allied health professionals who can help to implement that, our opportunities to meaningfully intervene are markedly negated. Just touching upon imaging for a moment, the penchant at the moment is to image everything that walks through the door. We get x-rays and MRIs at the beat of a heart. But the unfortunate thing is for osteoarthritis, this is a clinical diagnosis. It's based upon the symptoms and signs a person presents with. We don't need imaging to make this diagnosis. But unfortunately, imaging, particularly higher order imaging like MRI, drives up rates of surgery. At least in Australia, if you have an MRI for your knee osteoarthritis, 9 times greater rate of arthroscopy because you think your meniscal tear is why you've presented complaining of pain. It's not. But unfortunately, it drives up rates of surgery which don't provide any benefit to the patient at all. Okay, thinking about our common types of management, and specifically those that are more commonly used for the analgesic purposes in many Western countries again. Paracetamol historically was the first-line analgesic that was recommended for the management of osteoarthritis. It is no longer the first line, primarily because it doesn't provide a clinically meaningful benefit over and above placebo, and it has a side effect profile that makes it pretty similar to many anti-inflammatory medications. About 20% of people who have osteoarthritis are on long-term opiates. The current best evidence suggests it provides harm and no benefit. And obviously it carries with it real societal complexities here. And so in Australia last year, about 600 Australians died from prescription opiate overdose. A large proportion of those have osteoarthritis. So it's a huge societal problem, and it has no role in the management of this disease. But again, about 20% of people that have osteoarthritis are on long-term opiates. This is the College of GPs guidelines that we brought out last year, which provides a useful template for how management should occur. Includes doing a holistic assessment, making a clinical diagnosis, developing an individually tailored management plan. In an ideal world, we should be doing more of what's in green, being judicious about what's in yellow, and recommending against what's in red. So again, education, weight loss, exercise, regular review of medications, mood, sleep management, and so on. But by and large, much of what we currently do in clinical practice very much centers around here, and not necessarily judicious use of joint replacement surgery, which I'm going to come back to in a moment. So this is a program that we started back in 2011. At that point in time, the state government was really embarrassed about the amount of time people were spending on a waiting list for a knee or a hip replacement, oftentimes 12, 18, sometimes 24 months. And they said, David, is there anything you can do for these people while they're waiting on a waiting list? So we said, sure. We'll set up a non-operative management program, which I'll describe in a moment. But this is the status of what that was back now in about 2014 in these public hospitals within New South Wales. On average, about 70% of people who came in through these programs who were on a waiting list for a knee or a hip replacement had never had any appropriate management before they saw the surgeon and got put on a waiting list. So you can see there's a massive failing in our healthcare system. The gatekeepers here are not working. And all they do is get referred off to have elective surgery done, but not necessarily the other appropriate things which will provide a benefit to them. Within this community, we have obviously 2 to 3 comorbidities on average for the average person that has osteoarthritis. The most common ones include overweight and obesity, high blood pressure, depression, diabetes. And if our management makes those problems worse rather than better, and here I'm thinking about things like the management of blood pressure and the use of anti-inflammatories, the management of diabetes and the use of the steroids in particular, then we're failing again our patients. So lots of opportunities to make a meaningful difference to the other comorbidities as well. And here I'm particularly thinking about diabetes and heart disease with the management practices around weight loss and exercise that we're currently not optimizing in our community. So how do we traditionally manage osteoarthritis? And this is the pattern for about 80% of patients who have osteoarthritis is the person with joint pain presents to their GP who prescribes analgesics, and when they don't work any longer, they're referred off to see a surgeon. So that's the pattern of events for about 80% of people that have osteoarthritis. Ideally, what we would like to be doing, and this is what we're doing in New South Wales at the moment, person presents with joint pain, they see their GP, they're referred off for coordinated care screening. And in our program, that's coordinated by physiotherapists who are the gatekeepers for our program. And then they're referred off, depending upon what they need, to dietitians, psychologists, orthotists, occupational therapists, nurses, and medical practitioners for multidisciplinary non-operative management, enhanced self-management support, and then discharge back to the referring source. So that's the structure of our program. Ideally, it's built around identifying what modifiable risk factors a person has. So for example, if a person's overweight or obese, we advocate diet and exercise. If they're sedentary, we increase physical activity. If they're weak, we get them to strengthen and so on. So it's not a blast for everybody on every intervention known to man. It's tailored according to what they need and their modifiable risk factors. And it's a 6 to 12-month program, depending upon their success. I'm just going to give you one example from that program. So this is Bruce. He was listed on the joint replacement waiting list for a tight right total knee replacement. He had a 5-year history of knee pain and rapid deterioration over the last 6 months. About 10 years ago, he'd had an arthroscopy for that knee. He had a lot of other comorbidities, including high blood pressure, diabetes, sleep apnea, and obesity. He had radiographic osteoarthritis. He was a keen golfer. And in the program, he was referred off to see myself, a dietitian, orthotist, a hydrotherapist, and a physiotherapist. Through the course of the program, he lost over 5% of his body weight. And that's what we typically aim for, a minimum of 5%, but ideally more. He was able to get off all his pain relief. He halved his antihypertensive and diabetic medication. He was able to play 9 holes of golf weekly. He was able to travel, and he had no needs for surgery in the foreseeable future. And just to translate it into data, and this is the type of data that we usually collect in our program, his pain score, his visual analog score, went from 7 to 0. His ability to get up from a chair, walk 5 meters and sit back down, the time it took to do that halved. His body mass index dropped from 32 to 24 with a 22 kilogram weight loss. And so you can see lots of improvements, both in the management of his osteoarthritis, his weight, and also his diabetic control. So it's in that context, obviously we're managing multimorbidity, but his primary presenting thing was knee osteoarthritis. And that managed to get dramatic improvements. So again, it's a comprehensive multidisciplinary program that integrates various aspects, but targets pain, function, quality of life, and encouraging self-management. It incorporates a range of different measures. Not necessarily all of them are used, but we refer off to a lot of these programs to manage a person's symptoms, optimize function, improve quality of life, and ultimately, hopefully, to slow disease progression. We collect a lot of data. We've got a model of care that we're building this based upon. A lot of this is delivered face-to-face, but ultimately could be delivered remotely. And we're also measuring and monitoring this using validated tools. To give you a sense of what impact this has, so again, we start on people who, what we would typically consider a late-stage disease. So in general, these people have had disease for many years before they get on. And they're on the wait list and they've already seen a surgeon. So at least in our hospital, about 10% of people with hip osteoarthritis and about 15% of people with knee osteoarthritis are able to be removed from the waiting list. And they say, and this is their personal choice. So they say we no longer need surgery. It also has impacts on average length of stay. So in the hospitals that run these programs, you can see over time, we're reducing our length of stay following joint replacement. So a large proportion obviously go off and have their joints replaced. We're reducing their length of stay. We're reducing perioperative complications, and we're reducing rehabilitation requirements postoperatively. So I'm going to translate this into simple terms because the smarter economists in the room will look at this and say, well, I get that, but not everybody else does. So the average per year that's cost avoided in a program such as this is about $1 million. The average program costs about $200,000. So for every dollar that's invested, we avoid about $5. And that has obviously impacts on bed days avoided, separations avoided, and NWAs. So again, a dollar invested saves $5 in our healthcare system. If we were to do that from a societal perspective across Australia, what difference could we make? So if the average cost per person was $700 and we targeted the 10% of the population who are at high risk, that would cost our society $136 million. The net savings to the healthcare system would be $764 million. The net savings to the economy after we factor in the indirect costs would be $1.9 billion. So massive impacts that this can have from an economic perspective to the way our healthcare system is currently being delivered. Our program is one of a number, and there's lots of these internationally, and this is just a picture showing some of the ones that are largely through Europe, both Scandinavia and the UK. But there's lots of different programs now that are out there advocating for multidisciplinary, non-operative chronic disease management for people that have knee and hip osteoarthritis that are seeing similar benefits and effects to the ones that we're able to demonstrate in Australia. One of the other benefits here is that we're also diminishing the number of people who require a wasteful orthopedic elective procedure, specifically knee arthroscopy. There's good evidence to suggest, and that's been in existence since 1993, that arthroscopy does not benefit people that have knee osteoarthritis in terms of a clinically meaningful benefit over and above sham, over and above physiotherapy. And we're fortunate now that we're actually starting to see the rates of arthroscopy dropping. So in about 2014, it reached a peak of about 50,000 Australians per year having an arthroscopy for knee osteoarthritis. And that's dropped by about 30% in the last 3 to 4 years, finally because the evidence is starting to get through. Every one of these procedures costs our healthcare system about $5,000, carries with it a risk of clots of about 2%, a risk of death of 1 in 200. And so massive economic costs, massive potential complications, and no benefit to the patient population we're meaning to serve. For joint replacement, it's a wonderful procedure, incredibly cost-effective for the right person at the right time. Is it being delivered in that way at the moment? No. Up to 1 in 4 people that have a knee replacement have a bad outcome from their knee replacement, meaning the pain that they came in with is no better at 12 months after the procedure. So if I was told that I was going to come in and have a procedure that I was not going to be a 1 in 4 chance of not being better from in 12 months' time, I would really think about whether that's the right way to adopt and process this disease. We can usually predict those who are not going to respond. Either they're depressed, they're morbidly obese, they have little if any radiographic change, or they have low pain. So if we can predict those who are likely not to respond, ideally we should be triaging them to a different service. The other important element here is that the average person that has lower limb osteoarthritis has 2.7 joints affected. So that'll mean they have a knee and 2 hips that have osteoarthritis, or 2 hips and a knee that are affected. So if we replace one of those joints, it doesn't necessarily help the other 2 that still have osteoarthritis. A lot of people say that they have their joint replaced, I'll lose weight, I'll become more active. The data suggests the otherwise. So essentially, you have a joint replaced, typically you're going to continue to gain weight, and it usually doesn't change post-operative activity. This is a range of different studies that have demonstrated that the incidence of self-reported pain 12 months following total joint replacement is in the order of about 25% on average for most international cohorts that follow people following joint replacement. So again, 1 in 4 people following a joint replacement does not have a good outcome. The lifetime risk of a joint replacement is by far and away the minority of people that have osteoarthritis. But unfortunately, at this point in time, our healthcare system is structured in such a way that that's mainly the only thing that's currently incentivized and reimbursed. So you can see why people get shunted in that direction, but unfortunately for most people, they don't actually need it. Whether that's hip osteoarthritis or knee osteoarthritis, men or women, the lifetime risk of requiring a joint replacement for osteoarthritis is the minority. But unfortunately, our healthcare system is structured in such a way that that's all that's being offered. And if we look at projections for joint replacement requirement moving forward, starting obviously in 2018, moving forward to 2030, and this is data for the number of total knee replacements, you can see that there's a dramatic escalation. And since about 2003, year on year, there's been a 10% increase in the number of people having knee replacements. The cost for this procedure on average, at minimum, is about $20,000 per person. If that continues increasing 10% per year, and the GDP estimates suggest that our economy at the moment at least doesn't appear to be growing, you can see that this is not sustainable moving forward if we continue to do it the same way. So that's for knees. The projections are not dissimilar for hips. And at least in New Zealand, this is some data that Haxby has in press at the moment, the projections are very similar. So at the moment, my understanding is that you're producing about 6,000 total knee replacements per year, and it appears to be going up with no BMI increase, but obviously if there's a BMI increase by about 2040, you're looking at about 9,000 total knee replacements per year. Okay? I don't know if your healthcare system is set up to do this, whether you have enough surgeons to do this, whether you have enough operating rooms to do this. But I guess one of the main messages I'm trying to deliver today is that if we look at these projections and the increasing rates of about 10% per year, many economies are not in a position whereby we can sustain that. And there's lots of other alternatives if we coordinate chronic multidisciplinary non-operative care. This is a randomized controlled trial that colleagues in Denmark put out in 2015, where they randomized a group of people who were eligible for a knee replacement to non-operative procedure or total knee replacement. And you can see at 12 months that there is a statistically and clinically important improvement in the total knee replacement group. The important estimate here is that 74% of people who were eligible for a knee replacement at 12 months did not have one. Okay? So if they're provided an opportunity to have a non-operative program, a lot of them do quite well, 74%. At 2 years, 68% of them had still avoided surgery. So you can see, again, if they're provided the alternate opportunity for a non-operative program, they'll actually do quite well. And you're probably aware that obviously there are serious adverse events associated with knee replacement. The other aspect here is too, and this may not necessarily be the case in New Zealand, but we see massive differences in healthcare variation in terms of the apportionment of this procedure across the Australian community, such that communities whereby they have larger rates of private health cover, they have better access to surgeons and hospitals, are much more likely to get higher rates of surgery. Most of the procedures that are done in Australia are done as private elective orthopedic procedures. So about 2/3 are done for private patients. About 1/3 is done in the public system. And you can see from this that there's huge variations in terms of the rates of joint replacement across Australia, up to 4 times higher in some communities that have better access to hospitals, private insurers, and orthopedic surgeons. So it's not necessarily being driven by clinical demand, but rather being driven by opportunities for supply. So lots of opportunities for us to improve it. And these are some of the barriers to that. Obviously, patient factors, a lot of this comes back to appropriate education, adherence to treatment. I'm not suggesting to you that exercise and weight loss is easy. And sticking to this long term does have its complicating factors. Funders are also providing barriers. Oftentimes the government takes a short-term view of these things. A lot of what I'm talking about will have much, much greater impacts in 10 to 15 years rather than on a 3-year political term cycle. But ultimately we need to re-engineer the delivery of chronic care rather than looking at simply acute care where we react to the person who comes along with knee pain, give them an analgesic and refer them off to see the surgeon. If we can manage this much more proactively, get people engaged in their care, we're going to get much better benefit long term. And ultimately, we need to also educate our healthcare professionals. Just to reinforce this message, obviously, we spoke a little bit about prevention, spoke very much about living well with osteoarthritis. So that obviously, to me, largely comes back to the fact that we need to provide better access to non-operative management programs, which at the moment are limited both in terms of access, but also in terms of reimbursement. And that barrier in terms of cost is a huge issue for many of our patients. For advanced care, our priorities were largely centered around decision-making and shared decision support. So if we know that 1 in 4 people are going to have a bad outcome, we ideally should be sharing that information with patients who are sitting there in front of us who are contemplating having joint replacement surgery. So I want to leave you with a few thoughts. Obviously an incredibly prevalent and leading cause of disability in our community. Marked changing shifts in demographics. The projections are such that much of what we're currently doing, if we look at surgical trajectories of joint replacement requirement, they're not sustainable in our healthcare systems. And if we continue to do the same old thing, the same old way, our healthcare systems will break under the burden of that. So lots of different ways to focus this, both looking at prevention, but also particularly looking at non-operative management. I'd like to thank the slides have become more creative in time too, haven't they? I'd like to thank National Health and Medical Research Council, Arthritis Australia, my research group, the Institute of Bone Joint Research team and my clinical team. And very much thank you for the opportunity for coming along here today and your attention, and very happy to take questions. So thank you.